Well, hello, everybody, and either good afternoon, and thanks for joining us for your lunchtime today, or maybe brunch time today, depending on where you are in the country. Again, I see the attendee list. I know a few of you on there, so thanks for joining in to everybody. I'm coming to you from the Oswald COVID bubble here in Clearwater, Florida today, a nice day. So I hope everybody's having a healthy and safe start to the holiday season. It's a lot of interesting medical things coming out right now, kind of some mixed emotions on the fact that we still see rising COVID cases and hospitalizations, but yet the exciting news of the vaccine just about ready to roll out in the US. And I was interested in England yesterday or 2 days ago, how they started their distribution in Great Britain. And the second person to get the COVID vaccine, evidently they decided in England, just like here in the US, to base it on elderly at-risk patients would get the vaccine first. And the second person to get it, William Shakespeare. Now, he says he's 81 years old. I'm calling him out on that. He's 456 years old per my Google search. But certainly they're taking care of their elderly patients for sure there. Okay, guys, let's go ahead and we'll start rolling some slides here. So just a quick disclosure from me for this talk. I do have financial support that comes in from a CC Animal Health out of Santa Fe, New Mexico. I also do consulting for a variety of other firms, and you will see a product from PRN Pharmacal in today's presentation as well. So you might ask yourself, why is an internist, why is an ACVIM diplomat giving a talk on osteoarthritis? And I think there's two basic reasons. Over now 30 plus years in private practice as an internist, I see so many of my patients that come in for other issues that are on treatment, chronic treatment for osteoarthritis. And usually that involves chronic daily use of NSAIDs and many times glucosamine chondroitin type products. And, certainly has made me wonder, is it something that's a good idea for these patients to solely be on those types of drugs and those type of supplements for the management of their arthritis? Could we do better? And then the second reason is, for me personally, I developed back issues and lower lumbar issues and a chronic knee injury from playing sports in college. And I started getting to the point where I was getting close to thinking I had a knee replacement coming. And for me then to look into getting NSAIDs daily and getting steroid injections, taking glucosamine chondroitin, and really seeing limited improvements, I really got interested in the field more of arthritis and some of the alternative methods of treatment. And the good news is now it's 5+ years later, and through a variety of the things we'll talk about today, I'm doing much better in both of those issues, and my knee is still my knee, not a replacement. All right, guys, so all presentations begin with a cat meme. There's our kitty cat from an arthritis standpoint. Thankfully for these guys, this guy, the most interesting cat in the world, when he falls from his arthritis, he lands on his feet, which is a good thing. So I won't go into a lot of the pathophysiology. We as veterinarians certainly understand what happens through a variety of different causes, whether it be genetic, whether it be age-related, whether it be from some previous trauma to a specific joint or joints. We all know that we get a deterioration and a breakdown of the cartilage within our joints. We can end up with bone-on-bone contact, and obviously that elicits a tremendous amount of inflammation and subsequent pain. And so these patients certainly are in discomfort for a wide variety of the day. It's estimated that osteoarthritis, when we start to deal with more geriatric patients, affects upwards of 80 to 90% of the patients we see in private practice that live long enough to develop osteoarthritis. So it's certainly something that, we see regularly, although many times it's not the cardinal presentation on why the patient comes to see us. They may come in because they've got vomiting or diarrhea or some other issue, but yet many of our patients are concurrently affected with arthritis, and certainly something that, through questionnaires and good clinical history taking, we should always try to become aware of that for them. Clinical signs of osteoarthritis, it's very obvious to us as owners and to veterinarians when we see things like reduced mobility, obvious lamenesses and stiffnesses, Obviously, patients that are reduced in their activity, that their walks are shorter, they tire, they limp, and so on. But there's a lot of other things that go on, and it really is, again, a quality of life issue for both the pet and the owner. So many of these patients in their day-to-day activity can't do the things that they normally did. We see that a lot with, dogs that have difficulty on walks and stairs, dogs outside that have difficulty in posturing to eliminate, cats that have trouble getting into the litter box that they never had problems with before, cats that no longer can access window sills and furniture and so forth. And that also leads to, other things. Temperament changes are certainly a big thing. You see poor Grumpy Cat who passed away last year and Grumpy Dog here. But again, these patients become irritable. They're grumpy when they're touched. They're resistant to interact with their owners and maybe other animals in the household. They can spend a lot more time by themselves. So again, there's a big quality of life issue that goes into having consistent pain and discomfort from osteoarthritis. So I think for me, at least as an internist, a lot of the things that I look at with disease is drug-based. How do we treat things? It generally comes down to some, pharmacologic activity that's delivered through a drug. And I think for a lot of us as doctors, we, again, look at that the same way, and we sometimes overlook the fact that many diseases require a much more multimodal approach and not just drugs. I mean, drugs definitely have their place, don't get me wrong. We need to reduce inflammation and thus reduce pain in osteoarthritic patients, but there's a lot of other factors and ways we can go about doing it than just relying on consistent daily drug therapies to try to help, especially as patients get older. So we'll talk today a little bit about chondroprotectants and what their role might be, nutraceuticals, some ancillary treatments and actual devices that we can use that might reduce inflammation and pain. We'll talk a little bit about trying to optimize body condition, exercise and activity, and then also modifying the environment to make it easier for patients to get around. I hate to say this, I'm 58 years old and I moved into a smaller house. I downsized when my daughter went to college. And one of the big things we looked at is, let's get a house without stairs, because we know as we continue to get older, again, being mobile and up and down stairs is maybe not in our best interest. Again, from an internal medicine standpoint, for me, again, I see so many older patients with other disorders that involve the GI tract, the kidneys, the liver, the cardiovascular system, blood pressure. And we certainly know that as patients age, they develop diseases and dysfunctions, and they don't have the reserve capacity that many of these organs have in younger life and health. And when we start putting patients on consistent drug therapies, many times there's alteration of how those drugs are absorbed, distributed, eliminated. We may not get the maximum effect from some drugs, and we certainly may see more enhanced toxicity to certain drugs. We're all aware of that when it comes to use of NSAIDs. And our first goal, again, when you took your veterinary oath, is first to do no harm to patients. So we want to go ahead and take a look at how we can use, again, a multimodal, not just an NSAID drug approach. Now, when it comes to cats, I think we recognize more and more that, cats, although they have this small body stature and generally are such agile creatures, we sometimes forget that, or don't recognize that they also suffer from osteoarthritis as they get older. And we as veterinarians are all aware of the difficulty of giving medications on a chronic basis to cats. If we can do things that don't involve getting near their mouth and having them to take things, everyone's life is better. The problem with polypharmacy in cats and how it affects, again, adverse reactions to food, how it might react as far as their behavior withdrawal. Again, just treating cats is a difficult thing. Anything we can find that is not pharmaceutical based or oral based is maybe a good thing. All right, so let's go ahead and move into these treatments that we can certainly consider. So the goal of treating osteoarthritis, again, is certainly to reduce both local joint inflammation, reduce pain within that limb. And then as we talk about a little bit later today, we're also going to talk about trying to decrease maybe some of the alterations that go on in chronic pain syndromes that involve the spinal cord, what some people would call maladaptive pain responses, where chronic pain just leads you to basically continue to produce sort of a wind-up effect where the pain just never goes away. So when we want to reduce local joint inflammation and pain, the first place we always start, and we'll just briefly mention this, again, would be anti-inflammatory pharmaceuticals, drugs. I think we're all aware that glucocorticoids are certainly not designed for long-term use when it comes to this sort of an orthopedic issue. In fact, using consistent steroids, certainly will lead to not only side effects in the patient systemically, but they actually do potentiate ongoing cartilage and joint degeneration. So we really want to stay away from the cortical or glucocorticoid portion of things. In people, they certainly will use, longer acting steroid injections in joints, and will get you by when you have sort of an acute flare up at times. Certainly that approach is something that we don't see as much in veterinary medicine. But again, as a wholesale idea, we certainly want to try to avoid glucocorticoids. So that leaves us with non-steroidal or NSAIDs. And certainly NSAIDs are there to provide hopefully a fairly immediate and measurable response, improvement in joint function by less pain and less inflammation. And they're still the cornerstone drug, I think, for dogs. But we want to build upon that. We want to try to do other things that can maybe minimize our dependency then on using long-term NSAIDs. They've been off-label use in the United States for cats, although I'll show you just a brief slide that suggests that we certainly can use them, again, as a pain relief and inflammation relief measure for cats. As we all know, they affect prostaglandins. And there are prostaglandins throughout the body, not just in the joints, and we have to be careful of their impairment or their effect on the kidneys, on the gastrointestinal tract, on the liver, and even on coagulation. So our goal always with NSAIDs is if we see that we get that immediate measurable improvement, our goal is still going to be to not just leave that patient on and see you next year at your annual visit. We need to revisit these patients and figure out, can we get to a lowest effective dose and interval? Some patients maybe only need to take them here and there. Some patients may need to take them multiple times a week. Some patients are affected enough they may need to take them every day. I certainly won't go through all the different drugs in detail today, but recognize that we now have a number of different NSAIDs on the veterinary market. All of them are marketed and designed for some sort of basic approach to reduce pain and inflammation, but then also to maybe have a different activity where they may offer some protection to, say, the GI tract or less involvement with the kidneys and so on. I don't find that any of these drugs, honestly, for me as an internist, are superior one versus the other. So just like in people, and I can attest to this, you have to find the NSAID that is most compatible with the patient and provides the best relief. And so sometimes you may have to go through one or two of these to find that out. Again, I mentioned this with cats, that there are now some numerous papers, most of them in Europe and Australia, that do show us that drugs like meloxicam and robenacoxib, when used at appropriate dosages, are safe for longer term use in cats. The dosages are oftentimes about a half to a quarter of what their indications are for acute pain relief. But again, even though we have this evidence that we can use NSAIDs longer term in cats, I still want to be cautious with it. I still would like to achieve my lowest effective dose and my least frequent interval when using these drugs for cats. And I always want to make sure that cats are continuing to eat and drink and stay hydrated when they're on drugs like NSAIDs. If they become clinically ill for some other reason, we do need to stop these drugs immediately, as we certainly run the risk of renal compromise if we do not. Okay, so let's not focus on NSAIDs today. Our goal is to say, what can complement NSAIDs? What else can we use to try to decrease some of this reliance on those drugs? Well, probably one of the biggest ones over the 30 years of my career, and probably even before that, was talking about using natural things, nutraceuticals that are chondral protective. And basically that means glucosamine chondroitin. In theory, and that's not so much in theory, but in evidence-based medicine, in early joint disease, use of chondroprotectants like that does improve the elastic property of the joint. It does reduce synovial tissue inflammation. It can slow cartilage degeneration in osteoarthritis and maybe even contribute to some repair. So there certainly is a place for chondroprotectants like glucosamine chondroitins. But I think more and more what we know about them and recognize is there still are two things to think about. One is we have to initiate this type of supplement early in the osteoarthritis process. And you guys all know as veterinarians, it is hard in our field of medicine to start anything early because between clients not bringing patients in when signs are subtle and from animals hiding or at least minimizing some of their clinical signs, we oftentimes don't find things early. Also, once you do start these sort of chondroprotectants, it takes probably a month to 2 months to see any beneficial effects if it's going to occur. And a lot of times veterinarians and owners want immediate improvements. And if they don't see it, they give up on that type of product. We have a bunch of glycosamine glycans on the market. Cosequin, just by name, is probably one of the ones that's better known, but there's all kinds of other off-brand veterinary labels that are out there that contain glucosamine chondroitin and oftentimes hyaluronic acid, both in oral formulations, and you also have the polysulfated injectables like Adequin that can certainly be given for arthritis. So after all of this 30 years that I've been in the field, what do we know best about these? Again, they probably need to be used very early in the disease process and then continued long-term to really have an impact. Starting them when a patient has significant osteoarthritis is not likely going to provide you a lot of benefit and probably not going to help reduce your reliance on NSAIDs. So again, we kind of put these in the they might help, but certainly won't hurt category. But again, the miracle effect that many of us want with glucosamine chondroitin just isn't there. So what can we do? What are things that I think are effective that's going to help you, again, improve the patient and reduce reliance on NSAIDs? Well, number one, look at their environment. Again, we don't live with these animals unless they're your own personal patient, which I've got an older cat with arthritis here now. And we've had to modify our home so that Finster can get around better. Easier movement for him throughout the house, just like easier movement for me, no stairs. We have little jumping spots that he can get up with lower perches. He can jump up on a little box before he jumps up onto the bed or the windowsill. The big thing is we've gone from a litter box situation where we've gotten rid of the litter boxes with high lips, and we have the ones now that he can get into much, much easier instead of having to vault himself in and out over that top. We use heated beds, even here in Florida. That there's no doubt that he prefers compared to my younger cats at night to get in the heated bed. And I think it just soothes and makes his joints feel better. But anything you could do to make it easier for a dog or a cat to get around in the home. And again, this is more of the owner's responsibility, but we as veterinarians need to bring this point up to them and give them examples so that they can reflect on what does the environment look like that their pets live in. And what can they do then to make it easier to get around? Because that'll definitely help produce less stress on the joint, less inflammation, less pain. Okay. Now, weight loss kind of goes hand in hand with something that the owners need to concentrate on at home, and we need to be the referee, if you will, and monitor the situation to make sure it's being effective. But so many of our patients, I'm not going to dwell on this point, are overweight. And weight loss is actually an easy and cheap thing to do if the owner's committed to it. It doesn't cost a lot of money to take extra walks, to play laser tag with your cat. If you have a swimming pool, to get in the pool and bring your dog in for additional, or cat in for additional activity. Again, anything we can do to make these joints move. The last thing you want to do, and I'm a perfect example of this, when I was working full time, I'd come home and sit around at night. And my joints would stiffen up, and by the next morning, I went to work stiff. When I wasn't working as much and I started walking more, biking more, doing things to lose weight and keep my joints mobile, I was much, much improved on, especially my knee situation. So again, I won't go through all the dietary calculations. We all know these as veterinarians, but we need to encourage our clients to get these patients a little leaner and meaner. And we need to, again, follow that up. We can't just tell them we'll see you next year. They need to come into our offices once a month, weigh those patients, and let's be able to document that we are getting their weight down and that they are more active. Because doing that, again, can make a huge difference and reduce that reliance on having to use daily NSAIDs for many of these. If simply doing activity at home is not enough, if the patient is in need of professional help, there's a lot of availability now in our field for assisted exercise and physical therapy, and most major metropolitan areas now have somebody who is boarded in rehabilitation or has a center that can help with those things. Either with underwater treadmills would be a good example. And again, consulting with clients to set up specific activities and exercises that maybe can strengthen, the muscles and supportive periarticular tissues around specific joints that are maybe more affected, like your large breed dog that's had previous stifle surgery. But again, rely on that sort of program when needed to help, again, reduce our ability on drugs. And for owners' perspective, doing things like range of motion activity at home, massage. Look at this cat here. He looks just like my older guy, Finster. You tell me he's not enjoying that right now. If he's got any of those shoulder or neck arthritis, it's a great day for him. Look at that. So again, the more that we can get owners to buy into this physical type rehabilitation, activity, exercise, weight loss, it all goes hands in hand to reduce our reliance on drugs. I think medical assist devices don't get as much use as they probably should in our field. If you look at people with arthritis have all kinds of contraptions on their wrists, their elbows. I'm a golfer. I wear an elbow aid half the time when I play. But using these sort of things that give us better traction, using things like the lifts for stairs, especially for bigger dogs that are weak in the back end, to take some of that pressure off the hips, off the stifles, to use specific, for the smaller and more peripheral joints, to use specific stability splints or compression socks. All of these things, again, are inexpensive, non-pharmaceutical ways that we are treating the specific problem and not putting the rest of the body, particularly the kidneys or the liver, in any harm's way. And again, by getting patients more stability and traction, they're going to become more active. They're going to lose more weight. They're going to keep those joints more mobile. And again, we're going to see the benefit in a happier pet, a happier owner, and less reliance on drug therapies. Okay. Now let's talk a little bit about additional nutraceuticals that are not so much chondroprotective, but are nutraceuticals that would significantly maybe reduce joint inflammation, one of the core principles of osteoarthritis, and thus reduce, hopefully, local pain and swelling and make patients, less impaired. And those fall under, the anti-inflammatory nutraceuticals fall under several different types, but we'll talk about the three most popular, which are sort of your omega-3 fatty acid supplements, microlactin, and undenatured type 2 collagen are all things that are, again, nutraceuticals, non-prescription items that can be combined with these activity environmental modifications and NSAIDs that, again, will hopefully provide a patient improvement in their clinical signs. So looking at omega-3 fatty acids, again, I think we all know the story that it's not just joint specific, but there's numerous organ systems in the body that omega-3 fatty acids can help by decreasing arachidonic acid and the production of some of these inflammatory cytokines. When you have tissues that are under oxidative stress and are going to produce inflammation, omega-3 fatty acids will hopefully reduce some of the production of those inflammatory principles, and thus, again, reduce inflammation within the joint, specifically in this talk, and hopefully go ahead and make the patient less painful in the long run. Now, they have to be taken every day, either through oral supplementation or through dietary supplementation. And again, in older patients, one of the nicer things is that we also know that any patient with renal dysfunction really should be on an omega-3 fatty acid as well, because it helps renal and glomerular hemodynamics. So again, sort of treating the joints, but at the same time, treating the body as a whole. If you're going to go ahead and give the oral tablets, excuse me, guys, I'm going to decline that phone call there. If we are using the orally administered tablets, most of the time I would again suggest to you that you use a veterinary specific product. And based upon the label, if we administer what they tell us for, small, medium, or large size patients, cat or dog, approximately we're going to be giving EPA about 40 milligrams per kilogram per day and a DHA content of about 25 milligrams per kilogram per day. If you are using a prescription diet, for example, I have JM up here from Purina, those are going to incorporate your omega-3 fatty acids into the diet in the same levels. If the patient's eating the normal amount of food they should per day, they will be getting approximately this same level, and you really do not then have to give them a separate oral supplement, which is really nice for cats. I will just tell you, if I'm dealing with cats, a lot of cats absolutely hate the taste of orally administered omega-3 fatty acids. The one I've had the most success with, and this is just completely anecdotal, but my story is the omega caps, the snip tips. These EFA caps, for whatever reason, I've had more cats readily accept that either through a pill form or within their diet by opening the snip tip and placing it on there. So just for what that's worth, that's the one that I tend to go to if they're not getting it within their diet. Owners are always looking for treats. And from a treat standpoint, something that would be good to give, especially dogs, larger breed dogs or smaller breed dogs, we shouldn't discriminate there, would be green-lipped mussels from New Zealand. These specific mussels have a much higher glucosamine chondroitin content, so they may help in that perspective, but are also very rich in the omega-3 fatty acids and other antioxidants. So the same story, by giving this along with their diet, we may be able to provide plenty of supplementation to reduce inflammation by this antioxidative effects. Microlactin is a little bit of a different product, and you just have to give these products, for a month to 6 weeks, 8 weeks maybe, and see what the effect is and whether it makes a patient more mobile and more comfortable. If so, you can hopefully reduce NSAID dosages and frequencies, but there's no guarantee which one will work. So it really is trial and error. So I'll try omega-3 fatty acids. I usually like to continue those even if I don't see a measurable response. But if I don't see significant improvement for the patient, I'm going to think about things like microlactin, which is a totally different product. It's a milk protein, comes from hyperimmunizing cows. And then basically they're able to use this milk protein called microlactin, which actually inhibits inflammation through a different mechanism than what you'll see with steroids or NSAIDs. It inhibits cytokine production by reducing neutrophil migration and adhesion. So it basically blocks that inflammatory cascade through the use of an anti-neutrophil effect. Very safe profile on the GI tract, kidneys, liver. And so again, it can be used in combination with your other drugs and supplements to see if you get a basic response. What's a hyperimmunized cow? Well, I went on Google. I wanted to know. So I typed in hyperimmunized cow, went to images, and there's what I got, guys. You can see several of them. They are definitely hyper. And I guess like that one right there, I think that must be one they get microlactin milk from. Microlactin can be obtained in veterinary medicine through a product right now. There's several of them, but duralactin is an easy one to use. It's available both for dogs and cats, either in chewable tablets for dogs, capsules for cats. It can also be combined with omega-3 fatty acids, which is nice. So I normally would suggest using the plus combination. And that way, especially in dogs and cats, it eliminates having to double your amount of pills or capsules that you're giving. Clinical effects, hopefully within a week's time, you might see some early progress. But again, usually you have to give probably anywhere from 2 to 6 weeks to really appreciate whether you're going to see a reduction in inflammation, which of course would translate to improved mobility, attitude, and so forth in the patient. Okay. The last one of anti-inflammatory nutraceuticals would be to think about something like undenatured type 2 collagen. Again, this works through a different mechanism of action. It produces what they call as oral tolerance of the gastrointestinal immune system. So by giving this sternal cartilage from chickens is where they get this undenatured type 2 collagen. Basically, the immune system of the GI tract sees this foreign protein, this foreign collagen. It develops over time then a tolerance to it because there's nothing scary about chicken. And hopefully then that tolerance will relate back to the patient being more tolerant with their own cartilages and not subjecting them to as much of an immune attack as you would normally see, or an oxidative damage attack like you would see with osteoarthritis. There's been some limited studies in veterinary medicine that suggest that this works better than glucosamine chondroitin, which would make sense since it's an anti-inflammatory. But again, it may protect collagen and reduce inflammation. It can be, again, combined with omega-3 fatty acids, green lip mussels, microlactin. All of these things block inflammation naturally through different mechanisms that are, again, different than what NSAIDs do. And all are nice complementary things to consider. Again, it's just trial and error to see whether a patient does better or not. Okay, so let's go back then to drug therapy for a second before we get into some other devices. And in patients that maybe you're not getting as much improvement as you would like with the use of NSAIDs or any of these other supplements now we've mentioned, again, we have to remember that osteoarthritis is not just chronically, it does not just involve the joints themselves. In most cases, over time, I won't go into detail. I saw Dr. Grubb was listed as an attendee today. So Tammy, if you're out there, hello. This is Tammy's area of expertise as a anesthesiologist and pain management specialist. But we recognize that, pain is there to protect you. But in many times when you have chronic pain, it sort of just feeds upon itself, and you break down some of the normal regulatory processes in how the body processes pain, and we develop what's called maladaptive pain. So it becomes more of a spinal issue now, where the signals from my joints that are inflamed every day and are painful are not being satisfactorily blocked at the spinal cord level. They're getting to my brain and I hurt every day. Maladaptive. It's not protecting me. It's making my life worse at this point. So some people will call that maladaption or central sensitization, hyperalgesia, allodynia, a number of different terms. But it basically just means our body is reacting in the wrong way to chronic pain. So can we do some things to maybe address that aspect of it? So how do we block neuropathic pain? Well, we can either use non-narcotic drugs. We'll briefly talk about gabapentin and amantadine. And these, again, can be used in addition to all the things we've already mentioned in patients that are significantly uncomfortable to see if they help. Or we can use narcotic drugs. And we'll talk a little bit about narcotics, as I'm not a real huge fan of using narcotics for chronic pain with osteoarthritis. Yes, for some other systemic issues, but maybe not so much for daily use for osteoarthritic patients. And you can see this kitty cat over here. Meow is normally a good thing for a cat, but really when you break it down, it's me and it's ow, and there you go. He's got osteoarthritis. So gabapentin, Dr. Grubb just had a nice review in today's veterinary practice talking about gabapentin and amantadine. So I stole a little figure that she had in her paper. And this just shows basically some of the nerve endings in the dorsal horn of the spinal cord. And basically that's an area where if you have peripheral pain, it has to be sensed and then processed and sent to the brain for a reaction. And again, here's an area that we can selectively inhibit in some of these patients that are having these maladaptive chronic wind-up pain issues. Basically, gabapentin just inhibits, you see the G up here, it inhibits some of the calcium influx into these cells. And by blocking that calcium influx, we basically release, or we block the release of excitatory neurotransmitters like substance P and glutamine, norepinephrine. And by reducing the release of those, we get less input to the brain. So the brain is not sensing that we're painful. So we're basically able to block pain in that regard. So it doesn't do anything for the inflammation in the joint, but it's trying to handle it at a higher center. Now, gabapentin is predominantly renal cleared in dogs and cats. So you do have to be careful with dosing in renal impaired patients. Also some hepatic clearance in dogs. So if you have patients with other organ things that'll play into dosing. What do we know about dosing of gabapentin? There's a variability like many drugs in oral bioavailability. And once a drug does get absorbed into the system, it has a relatively short half-life in dogs and cats. Traditionally, when we use gabapentin for things like an adjunctive seizure control, and we've used it for spinal cord patients, most of us were trained to start at a relatively lower dose, like 5 milligrams per kilogram twice a day. And because of the fact we don't use a drug like gabapentin that often in many of our practices, oftentimes we're not experienced as practitioners in considering how to adjust that dose if we don't get the clinical response we're looking for. And so when you look at the dosages really of gabapentin for dogs or cats, 5 milligrams per kilogram is probably a starting dose twice a day. In many cases, you will have to raise that dose upwards of 20 milligrams per kilogram, doing it gradually based on clinical response. And in some cases, as high as 50 milligrams per kilogram. And although we say every 12 hours, there are many, many patients that probably require, because of the short half-life, every 6 to 8 hour administration. So if you start a drug like this and you're not getting the response that you desire, whatever that is, whether it's better mobility, the patient, it takes longer walks, whatever the clinical endpoint you're looking for, if you're not seeing that, we need to continue to increase the drug dose. And again, also maybe give it more frequently. The end result is if we see that we get side effects, which predominantly is sedation, fairly easy to recognize for the owners. If we get to the point we're getting sedation, then we know we've reached the upper limits of what we should do with that drug. If we do get a response at the higher dosages, then sometimes we can reduce that dose and then continue to use it long term. But again, don't be overly afraid of gabapentin. Try more of the dosing, give it more frequently, again, up to the point of sedation, and check in frequently with clients and make a plan to, if I don't see changes in a week or so, I'm going to be increasing my dose sequentially. One thing to remember is that the commercial solution on the human side, if you're using a solution instead of capsules or tablets, it does contain xylitol. And remember, that can be toxic to canines, especially smaller ones. So if you want to use an oral solution, I would suggest it's best off to have it veterinary compounded, and that way it will not contain xylitol. Amantadine is another drug that is similar in what it does as far as blocking some of this neuroexcitatory central sensitization. Again, going back to that same thing, amantadine works on the postsynaptic side where this nerve has been activated, and it goes ahead and basically blocks the NMDA receptors. So it's an antagonist of methyl D-aspartate. It's almost like ketamine. It's a very similar type drug to ketamine. And basically, again, it's able to block that excitement of that nerve and hopefully start restoring some of the balance and getting rid of some of this maladaptive type pain that the patient is feeling. 3 to 5 milligram per kilogram once a day has been the established dose in most textbooks, although we do recognize that there are probably many patients, if you don't see an initial response to that dose, should take it twice a day. The more recent studies in pharmacy or pharmacologic parameters would suggest that every 12 hours may be better for many, many patients. Very high oral bioavailability for this drug, so that's good news. That's why the dose is fairly tight. It is renal eliminated, so again, be careful with older patients if you're using it. It's getting more and more use now in dogs, less experience, I think, so far in cats, but overall, the good news, it seems to have a safe profile. If we were initially concerned with a narrow therapeutic window of this drug, I don't really think that's been the case. Our experience has been fairly safe and good so far in veterinary medicine. And if you do see things like anxiety, restlessness, maybe a dry mouth type syndrome, diarrhea, they've all been reported that might have to impact your drug dose or the use of this drug. But again, these are drugs that can all be sequentially stacked on top of each other. All of the things we've mentioned so far this morning, from NSAIDs through supplements, through gabapentin, through amantadine, can all be used, again, as a multimodal approach along with that activity, that exercise, that weight loss, and so on. All right, let's finish up drugs here with narcotics, then go into a couple of other things. So tramadol, as an internist, I'm very disappointed in tramadol. I have seen so many of my surgery colleagues placing animals on tramadol. And I think the more and more we know about it in dogs it just really is not a very effective narcotic type drug. Again, even though it does go ahead and stimulate the mu1 receptor, it just doesn't seem to do that very well in dogs. It does have some effect on central serotonin and norepinephrine uptake, and that might help with some of that maladaptive pain in osteoarthritis. But I think overall, most of us now have come to a conclusion that even despite proper dosing that I have down here, it has not really been a very effective drug. Definitely not standalone, but even when used in combination with other things. So I'm not a real fond person about tramadol. And I think studies back that up with us, that it's been not only conflicting, but the more recent studies fairly ineffective analgesic activity in dogs. Now in cats, it does seem to have a fairly moderate analgesic capacity with the M1 metabolite. It's greater in cats versus dogs. Bioavailability and half-life seems to be better in cats versus dogs. But I'll tell you what, practically, cats are smart individuals and they absolutely hate the taste of tramadol. It seems like no matter what you put it in or try to hide it in, it is very, very almost impossible to get cats to take tramadol. So in that instance, that's again a big limitation for why it really is not very effective in the use for osteoarthritis. There's lots of other narcotic drugs out there that I'm not going to talk a whole lot about because, again, narcotics don't seem to be the way that we really want to treat osteoarthritis pain. Long-term daily narcotics, we all know from experience with people that there are drawbacks to that use. And we do see a lot of things like appetite changes, attitudinal changes, constipation, that all limit a lot of our use of these sort of drugs daily, long-term for osteoarthritis. If you have a patient with breakthrough pain, where you really just need to treat them for a couple of days, maybe they had a stifle that was surgicated years ago, and they went ahead and twisted it, and it's going to be painful for the next couple of days, then certainly using something like buprenorphine for acute breakthrough pain for a time-limited period would certainly be fine. But outside of that, chronic use of narcotics, I think, again, all the other things we've mentioned today would be better. Now, what about non-drug therapies? Our sponsor today, CC Animal Health, has been one of the leaders in looking at pulsed electromagnetic field therapy. And I'm very interested in this because in my research on my own knee and seeing my own knee surgeons over the years that no one really wanted to do a total knee replacement for me, they turned me on to things like the pulsed electromagnetic field therapy. And I do believe in my case, it made a difference. And I've had a unique interest in that field since that time. Basically, this is low voltage electricity that's produced by a sensor or transducer that's sent out in this case, a circular waveform on both sides of the device. This is called a loop. And basically, if you're within this field of low voltage electromagnetic field, it's going to have an effect on the local tissues, influencing predominantly calcium and nitrous oxide production. And basically, in the way it targets these tissues, the theory is that it influences how cells within the field alters their metabolism to basically be less inflammatory, less pain transduction, hopefully inducing mitochondrial changes for tissue growth and repair. And again, hopefully benefiting tissues that are chronically inflamed. Lots of studies in the human side that go back over the last century. In veterinary medicine, most of our experience has been within the last decade. But like most things, we don't have a tremendous amount of evidence-based literature that's come out so far. But there is a paper that was just published actually last year out of New York City that looked at using electromagnetic field therapy after hemilaminectomies. And they were able to show in this study that the reliance on narcotic use for postoperative pain was much less in the patients that were treated concurrently with the electromagnetic field therapy as part of their treatment arm. What I really like about it, and this is the thing that got me involved with the SISI and why I like it, is it's a home therapy. Your patient and client doesn't have to travel to you or to somebody else to provide this form of osteoarthritis treatment. It's drug-free, it's non-invasive, it complements all the other therapies that we've talked about today. And again, hopefully reduces the dependence on some of the things, especially like NSAIDs, that may have a potential for harm in older patients. They can also be targeted to individual sites or to sort of the whole body, if you will. When you look at these loops, you can either go ahead and purchase them in different sizes where they can be slipped directly over the area of interest, in this case, an elbow. And of course, there's going to be an electromagnetic field radiating up and down that arm to cover that joint area. They can be placed with a vest over specific areas like shoulders or specific vertebral areas when a patient is mobile. Again, in cats, they can be placed on the body like this and just lean. This is what I do with my cat. He's actually a yellow male, just like this guy. And you can lean that loop along here for, in this case, coxofemoral relief. So it's a pretty cool thing. And what I really like about it is, for smaller individuals, and I guess it can depend, you can do this with bigger individuals if you can fit them in an area of confinement as well. But my cat loves to sleep in a cat bed, and I can slip 2 of these loops underneath and provide an electromagnetic field that basically is encompassing most of his body, since these things go out multiple inches on either side of the device itself. This would be called the loop lounge, where while they're sleeping, you can be treating them. Initially, these are 15-minute sessions that you would provide, usually 2 to 4 times a day initially, over the first 2 to say 6 weeks, looking for some sign of a positive response. And once you see that, just like anything else, you can taper how often these treatments are given, but they're safe. Again, they're non-invasive. And if you have to continue doing them on a daily basis for pain relief, it's certainly fine. I used one for almost 2 years on my knee, and now I use it occasionally. After I play golf, I come home, I'm sore. Next couple of days, sometimes I'll go ahead and do, again, the pulsed electromagnetic therapy. So I think this is something that's interesting. Again, at least based on a recent paper, we have some belief that it does do what it's supposed to do. Again, it's not an end-all, be-all treatment. It's not going to cure arthritis, but it certainly can only help. Other things that can help, and again, can be used concurrently, acupuncture. Again, acupuncture, again, will stimulate these specific neurohormonal processes in the area where you place the acupuncture needles, again, designed to reduce pain transduction. I think it's a good therapy. As an internist, I've always been more of a traditional person and shied away from a lot of the complementary or homeopathic type therapies till later in my career. But I'm an evidence-based guy. I like to see things that work. There's not a whole lot of literature out there that I can see traditionally in acupuncture, but I have many, many patients over the years that I have sent with arthritis to clinicians that do acupuncture here locally, and the owners rave about the appearance for some dogs and cats, and other ones they come home and say, "Doc, that was an absolute bust and it didn't help at all." These are all patient-specific treatments, but should, in my mind at least, be something you should be considering. Only drawback for acupuncture, you got to go somewhere to have it done. It's an outpatient therapy, but again, drug-free, minimally invasive. You're sticking these tiny little needles in. Probably no side effects or adverse effects unless you get a little too aggressive with that needle. That's why I probably shouldn't be doing it. But again, it certainly may help reduce the dependence on other things. Cold laser, I'm not sure what exactly I should say about cold laser. Same sort of phenomenon or thought process, that using cold laser therapy, these photons that are emitted from the laser are going to go ahead and basically be absorbed by the cells that they're emitted over through a process that they call photobiomodulation. This will activate mitochondrial RNA. And again, you'll change cellular metabolism, hopefully increase circulation, reduce some of inflammation modulators, hopefully reduce pain transduction, and promote tissue healing. So lots of things that this modality may do. Again, it's an outpatient therapy, so you either have to do it in your practice or know someone that does it, and you have to go and have multiple treatments done. So it's not something you can have done 1 or 2 times and expect a long-term response. Again, drug-free and non-invasive, which is great. No adverse effects as long as you wear the really cool little glasses to prevent your retinas from being exposed to the laser. And again, certainly may reduce the dependence for other treatments. I will just say to you that in my referral practice and in my use of laser therapy for patients that I've referred both within a house and out of house to have it done, I have been less than impressed with most of the reports from what my clients see. So I'm not sold that laser therapy is a wonderful thing, but again, it's a tool, it's in your toolbox. It can be considered. And for certain patients, it certainly may help. Remember, there's always a placebo effect with any of these treatments. But overall, I've been disappointed, I would say to you, with the laser therapy. Some new things on the horizon, of course, stem cell therapy, platelet-rich plasma therapy, most of the time done for one specific joint that's a problem. I think we're a little bit too early into what goes on with these therapies to know much about success rates or how much they would be curative or significantly reduce the dependence on other treatments. To me, I'm going to allow, I think, a little bit more time and study to be done till we can really see the effects. And the good news is some of the universities have really taken this up and they are looking into it. So it's not something that is quackery. But again, if we can see that there are evidence-based effects that really make this worthwhile, then it's worth doing. Obviously, it's invasive. There's considerable expense compared to a lot of the other treatments. Those are probably some of the reasons why I don't go to this as a frontline therapy for me. And then, oh my God, I don't know what to tell you guys about cannabinoids. Every single day in my mailboxes, and I'm sure in yours too, you get invited to a seminar just like this to talk about cannabinoids and CBD use in animals. Again, I think from what I can gather right now, it doesn't appear harmful. I think there's probably a huge placebo effect in what people think and see when they use cannabinoids and CBD in their patients. I think there may very well be a beneficial clinical response in many of these patients as well. But again, studies are just ongoing. We're at the tip of the iceberg with this supplement. And I'm going to let a little bit more time go by before I make it a routine recommendation for me, at least. Of course, there's legality issues potentially in some states with that. And again, the hardest part is we just don't know that much yet about products, dosing, but that information is coming. And again, universities are stepping up and looking at this, which is good. All right, guys. So in summary, what do we talk about today? I mean, bottom line is there's a lot of things out there for osteoarthritis. It's not all about NSAIDs. It's not all about take this drug every day, it's going to help, and we'll see you next year for your annual exam. It's really about treating the patient with a multimodal approach. And again, that includes a lot of different facets. And I cannot underestimate how important things are like weight loss, keeping the joint active, changing the environment so that you don't put as much stress on bad joints every day. Again, these multimodal complementary treatments, choose your drug therapies wisely because drugs can potentially have side effects. Be aware of what else is going on in your patients. Start treatment early, especially with chondroprotectants. With any of these anti-inflammatory drugs, escalate as needed and then back off if the patient's doing better until maybe they have another significant flare-up. Non-drug therapies should be part of your multimodal approach. Anti-inflammatory nutraceuticals, support devices. Again, things like pulsed electromagnetic therapy, acupuncture, again, swimming, underwater treadmills. All of these things play a complementary role to each other in making patients do better. And I'll tell you what, you guys all know as well as I do, it's all about if the client's happy and they see improvement. A lot of these things, they can be done at home. If they can buy into the process, they get self-satisfaction, just like we do when we see patients get better. And then lastly, always be careful with polypharmacy in cats. Any of these things that we can do that can be non through the mouth when it comes to cats are certainly going to be better for that species in particular. So I think those are the things I wanted to really talk about today. I hope you got some value out of this from an internist perspective. This is at a dog named Stella. And this would be a dog would be ultimately important to be sure that if she develops osteoarthritis, you don't want her joints to hurt, because she has a very specific activity that this dog is manically crazed about doing. Hello, Stella. Hello, leaf pile. Hello, Stella. Go. Yeah, that's a dog there that we definitely want to keep mobile and doing fine.